Okay, so you can see the basic announcement. There it is, black and white. You can see. So that is, I'm just making sure, reinforcing everybody. Hopefully tomorrow sometime, depending on my schedule, surely in the next couple of days, I will get a review recording together. I do have to make sure I have everything finalized for the exam, and I will get that sent to you. So just that's a little bit of internal housekeeping there for that event, because we start a new unit today. This is our last unit. This is all the information that's on the final exam, and I will demonstrate that. I will discuss that rather with you now. This involves these chapters. This is really the perhaps as much of the physiology of the nervous system as anything else. The first PowerPoint that we'll be doing, we'll get a good portion of it done today, is more anatomy and just some generic discussions about what the structures do, or what their roles are. That would be the limited physio- physiology of it. The next one, which we'll probably get to mostly, maybe introduce Friday, which you'll see most of it next week, is really the physiology of the nervous system. And the last of these three PowerPoints has a lot to really spends a fair amount of time on neurotransmitters, which is very important. There is a whole lot of content in this. So this is our unit 4. That's what we're looking at. There are really one chapter we do that involves, because I know a lot of it is somewhat reviewing the structures in the brain that you're already familiar with, but focusing a little bit more on the physiology. We'll talk about the linings that are there, a little bit more in earnest about the ventricles, a little bit more of the different roles that are there, go over a little bit more of the spinal cord anatomy, et cetera, et cetera. And the very last chapter we do for this, that we conclude with, and we'll probably be doing that the very last week. I believe we have 1 week from when we come back from our Thanksgiving break, and then exams, finals are after that. I hadn't thought of this, but we always start finals on a Tuesday. My guess is Monday will be a review day for that final, whatever that date, whenever we come back, whatever that date is. I don't recall. So it's 2 weeks from the 17th. So was that December 1st, something like that? Really? Got that right? What? Because there's no 31st in November. 30 days has September, April, June, and November.
You got it, December 1st.
I haven't lost my fastball just yet, despite what many of you think. So I'm allowed to joke about that. Now, on with the show. So today's discussion is beginning an introduction. This is when they say nervous system and nervous tissue. Really, this is looking at it more or less on a microscopic basis, really getting into it rather than sitting there, the frontal lobe. And even though I'll do that, frontal lobe does this and parietal lobe does this. But in anatomy, you're looking for where they are and what the structures that are associated with it. Here, it's more physiological. This is, you have two major controlling systems, and then they're interactive with one another. One is the nervous system for very, very fast responses. The other is the endocrine system for slower, and not slow. We were talking microseconds for the nervous system. And we were talking maybe seconds, minutes, hours, days, weeks for the endocrine system, depending on the system. So you don't get to do endocrine until AP2, but you get a little bit of endocrine here, particularly when you get into the last portion of this, which is really that last week called the autonomic nervous system, because it's really, if anything, it impacts a lot of endocrine system activities. So this is the big player. And again, it's an electrical system that communicates with other nerves and other structures by way of chemicals. You saw that. That's why it reinforces what we learned about the neuromuscular junction. Okay? And again, extraordinarily rapid. When you think about it. I mean, there's any number of ways to think about how rapidly we do something, and then what our body feels like. That's sort of the distinction between the nervous system and the endocrine system. Like all of a sudden you're on driving, and almost happened to me this morning. Some idiot decides to pull out from in front of me and squeeze into two cars in the fast lane going when I take 79 south in Cranberry. I'm like hitting the brakes. Oh my God, there's gonna be an accident. It's so fast. And then after that, it's like, I thought we were gonna. It turned out it really wasn't a big deal, but it's like, whew, what was that so and so doing that I verbalized loudly, comparing him to an anal orifice, if you know what I mean. It's inappropriate to say asshole. I'm sorry, never mind. How does it work? Incoming signals. You're going to continue to see the term, if you haven't already, called afferent. And we always accent the first letter to avoid being uncertain. An afferent is an incoming signal. We derive the term efferent or outgoing signal because it came from the word effector. The motor division create not just movement, but creates action. So it brings things into effect rather than affecting them, if you want to get technical. But that's sort of the term. So I always use effector because if you say afferent and if you say afferent and efferent, you can get confused. And the thing you must avoid when you're in a clinical field, when you're dealing with people, is to avoid confusion because of subtle differences in the way words sound. And that's why we do abduction and adduction, that kind of stuff, etc. And everything else, so these are sensory, these are motor. Everything else is integration. The vast majority of our nerves are integration nerves. We call them interneurons, 98, 99%. That gives you an idea of how much, just look at the distribution. Nearly all of them are in between processing nerves. And that's the way our bodies work. That's the way our mind works. We take in information, we make that determination about what's going on. In the example of the car, maybe having to make a quick maneuver while in a vehicle, that's a perfect example. Think of how lightning fast you're processing what you saw, what you heard, when you got the picture, because you're always very alert when you're well, you should be, obviously, in a vehicle, and then having to do something very, very quickly. So it's all about processing. And there's so many analogies. You see something, make a determination. That's again the integrative portion, and it's not typically the one nerve circuit is the rarest. No, beg your pardon. Is the least complicated. That's a simple reflex. That knee-jerk reflex, basically a one nerve, basically a circuit like this, one in between or integrative nerve. We'll get to that. That's another lecture. Divisions. First thing you learned about in lab. Should have been the first lab I would expect it was. You learned about those dorsal body compartments and ventral body compartments, thoracic cavity, diaphragm, abdominopelvic cavity. The dorsal has one thing in it, the central nervous system. The definition of the central nervous system, brain and spinal cord. Anything that sticks out is part of the peripheral nervous system. And by definition, if it sticks out of the brain, it's called a cranial nerve. You learned about those. And if it sticks out of the spinal, they are spinal nerves. Okay? This is so effectively the processing plant for the incoming signals and outgoing signals is the brain and the spinal cord. Interprets, dictates, blah, 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 responds to it in some way, shape, or form. Stores that information in some way, shape, or form frequently. So the peripheral nervous system sticks out, protrudes, whatever word you want to use. This is a recurrent construct to be familiar with. Because by this time you should be getting used to the way I ask questions. If I use the word CNS or PNS, which are perfectly acceptable acronyms, that frames the question. Those are the little things when I write on the test, that's what you underline, what you highlight in some way, shape, or form to give you an idea how to quick, because that's easy to go wrong. You'll see in a second. Part of what I'm trying to give you guys test taking strategy and test taking tips, things like that. We talk about it all the time. That's one of the big, when people enter into the undergraduate environment, their test taking skills, many of them are very limited, not all certainly, but most of them need refinement. Here's what it looks like. No big deal. Not an important diagram. But there's a whole bunch of nerves. So again, sensory are afferent. You'll see the terms somatic and visceral. Somatic means of the body. And what it means effectively, it's your body and your sense of this is classified as skin, muscles, and joints. Visceral means organs. Organs work, we don't have a lot of sensory input from organs. We don't have a lot of motor output to organs. Organs kind of work on their own with respect to the nervous system. The nervous system is keeping it in check. And that's when we start looking at the very last chapter, we do the autonomic nervous system, because that's really it's an elegant example of how homeostasis works. Very, very much so. And so that's where you get the term somatic means of the body, visceral, the terms that you'll see. Where motor, same deal. The efferent portion that's going to the body effectively is muscles and glands. Okay. And so that's the somatic. Anything else that's really going to motor signals going to organs is known as the autonomic nervous system or the visceral motor system. You'll see the construct. It's not the kind of stuff I would be planning on asking you. I'm trying to give you an idea. So that autonomic system is pretty much a motor system. And that, again, it's a separate chapter. So here you are, somatic nervous system, impulses from the CNS, the skeletal muscles that are there, voluntary control, fine. So you have incoming and outgoing signals that are part of it. These are the outgoing signals. And the autonomic outgoing signals to the things we talked about last time. Smooth muscle, the things that we're saving, or I'm making sure that you will cover in AP2, heart muscle, glands, which are part of endocrine. Again, involuntary. And that's when you're going to see this down the road when you get to autonomic. We'll go over this in some degree of length to understand the homeostatic relationship that they have. And you always see this illustration, at least in this particular PowerPoint sequence. A lot of textbooks use the same illustrations or constructs. So again, here's peripheral. We have incoming and outgoing, afferent and efferent. Not even talking about the processing and whether they're going to the body, the outgoing, or to glands, and then they subdivide that. And we'll go over this. You'll see this again when we get to autonomic. Done with that. Thank goodness. Now we finally get to the nervous system. And we're not even going to talk about the nerve anatomy very much today at all. We're going to talk about the supporting cast. And it's funny, a lot of things, you'll see this again. Maybe not the same, identical, but a lot of what you did in the early weeks of lab, when you start talking about lining tissues and connective tissues, this is where you build on those things. The unique area about the nervous system is it has a totally different kind of supportive cast. It has 4 different kinds of cells that become the connective tissue of the nervous system. And we find the central nervous system and 2 more in the peripheral nervous system. The name we give them is glial cells. Everything else is a nerve cell. The nerve cells many are the same. There's some that are anatomically different. I'll point out the differences to you when we actually look at the nerve cell itself. But the big deal right now we're going to talk about are these supporting cells. They are the connective tissue. When someone gets brain, you're going to see this later. So I'll get ahead of the curve. Nerve cells are what are known as amitotic. They're like skeletal muscle cells. Can't make any more. They're there. Can you make more connections? Absolutely, but they're there when you're born. So when they're damaged irreparably, they die. You can't get new ones. That's the bad news. The good news, okay, they don't get cancer. What is brain cancer? And as someone usually asks me, so I just anticipate the question. Brain cancers involve the glial cells. They're like any other connective tissue cell. There's an element of growth that's associated with them, an element of mitosis that's associated with them. Okay? So as brains develop, a lot of it involves the development of these glial cells. Typical brain tumor, you will see they'll call it a glioma. About 90+% of brain tumors are benign. Why are they so dangerous? Limited space up here. Tumors are what we call space-occupying lesions. A lesion is something that's there that should not ought to be there. It's a generic term. When it occupies space and it starts to grow, it's going to compress or push the stuff that's important against the wall. That's hard, and it's going to crush it, damage it. That's why they cause such big problems. So you'll hear gliomas that are there. The glia means glue. Technically, this is the glue that literally wraps around delicate nerves. And then we'll get to the nerves later. These are the ones that are up there. So you can see that I wrote them down just to give you an idea. But this is typical question. Central nervous system or in the peripheral nervous system. Now you begin to understand what cells are what. Two of these cells are similar. There are two of the cells here that are found only in the peripheral nervous system. The satellite cell and the Schwann cell have similar, and in some cases identical roles to the ones that to the four named here. The astrocyte, okay, and the reason I have this with a little question mark is short for we're not sure. The satellite cell has a similar but surely not an identical role. By and large, it's a we don't know. The oligodendrocyte, very famously, is associated with something called the Schwann cell. So that's part of the discussion today when we talk about myelin. All that white matter when you did the brain dissection, myelin. That's all those are long tails, long projections of nerves that are wrapped in something called myelin. Myelin in the central nervous system, the brain, comes from oligodendrocytes, peripheral nerves, median nerve here when you get carpal tunnel, Schwann cells. So one of the tumors we see a lot peripherally is body schwannomas. We even get malignant that are there. Ependymal cells is kind of a lining cell, and microglia is sort of like a scavenger like type of white blood cell, as you will see all shortly. Those 6 names you got to know. Moving on. This is the big player. These contribute to, they're not the most important part, but they contribute to something called the blood-brain barrier. What's unique about the brain is that things in your bloodstream where in other areas of your body, say maybe one in men, testicular area, and when you get to the capillaries, there's little openings in the capillaries, and basically stuff can get through, whether it's not just oxygen going out and carbon dioxide coming in, but nutrients and waste products, all sorts of stuff. Not in the brain. The capillaries in the brain are very unique in the sense, and this is where you get back to that basic anatomy, they have a lot of these things called tight junctions. And tight junctions means watertight. And things that are water soluble cannot act on the brain. When we use medicines, when someone takes a psychoactive medicine, someone takes whatever the names they're using today, how they Paxil, Prozac, Zoloft, whatever commonly used things that are there, all of which many of you will learn about in pharmacology. So those are common for mild depressive, obsessive compulsive. We'll even talk about the category in this class called SSRIs. Basically, they can get through because they're fat compatible. Very important. That's because of this thing called the blood-brain barrier, which we'll review again. It has to do with the capillaries, the tiny lining cells that basically capillaries are made of, with abundance of tight junctions, and they're watertight. And so the astrocytes surround it. They add to that barrier, number 2. And literally, I'll show you in the illustration how the materials have to flow out of the blood vessels through the astrocytes and into the nerve, and waste products coming in the opposite direction. But these are the ones you have the most of, and they have the most role. They're part of development. They're part of function. So they cling to the nerves. They cling to where they meet other nerves, synaptic endings, and they cling to the capillaries. So they're supportive in nature. They hold things together. I just was explaining to you in a little bit of detail the role that they play in the exchange. They are part of development. Think of developmental landmarks. When we're born, we are basically a newborn baby can do very little for themselves. Most of us know that perfectly well. Okay, so look at those developmental landmarks. 3 to 6 months, they can start to control their head. Somewhere between maybe they start to crawl 6 to 9 months. Somewhere magically from 12, and these are all averages. Between 12 to 15 months, they start to walk. Got it? Every parent in the world, every big brother and big, oh my God, they're walking, they're doing this. Everybody's so excited about it. You know, moving and clicking. Everybody in the family gets them. I know I get them. Okay. Those are all because of the role the astrocytes are playing in guiding these nerves, okay, where they're moving to, etc. They literally, because the nerves, again, it's for something that potentially would be harmful, would be controlled by and limited the exposure to, that is the bad substance, so to speak, to be by the nerve. They're impacted by other nerve impulses, and you're gonna learn all you could possibly want to know about neurotransmitters. That's in the very last of these 3 PowerPoints that are there. So they're very influential, and they do play a significant role in information processing. Lots going on. That's what they look like. It's a good illustration. Here's this cell. Astrocyte means star-shaped cell. So star shape, it's like many, many projections, okay, that are there. We see that a lot, okay? So multiple tentacle-like projections, the way I tend to describe it. Here's these unique capillaries, and yellow here's the nerve. So literally for something that can get, it has to get through the capillary membrane, or the capillary cell has to get through this appendage of the astrocyte, make its way through one of these tentacles into the nerve. And at the same time, if there's a nutrient going in this way, then a waste product would have to come back in the opposite direction. Oxygen would come in this way, carbon dioxide would go in the opposite direction. That's why they play such a pivotal role. Basically, they're controlling what's going in and what's going out. And the limitation kind of comes from the capillary because of this abundance of tight junctions. That's the blood-brain barrier. We're going to go over it yet again down the road. It's terribly important to be familiar. Next cell, microglia. These are the two that don't have, the astrocyte you're going to see has, these next two you're going to see different, but the astrocyte is similar to a cell we call the satellite cell. For years, we taught that we don't really know what the satellite cell does. They speculate it has a similar role. When we get to the peripheral nervous system, don't know. So small cells, again, lots and lots of projections, and that's very characteristic of white blood cells. When you study the immune system in the blood, the white blood cells in the blood, white blood cells have a lot of projections where they latch on to stuff. This is the same for these. So they basically play this role. Okay, they migrate toward injured nerves. When nerves are injured, nerves undergo, they can be destroyed, but the injuries are something that sometimes are reparable. They can repair those, and they're gobbling up debris. When you see all the stuff that goes on, making neurotransmitters, making conduits and passageways, the recycling of those materials that we talked about a little bit in the neuromuscular junction, that's where they go to, and they gobble up bad stuff, potentially microorganisms, which would be very, very dangerous, obviously, a variety of debris that comes off. So they play an important role, a scavenger-like role. And they're in contact a lot, and this is the diagram that they would use. So defensive is really a good word to describe their roles. Somewhat analogous to the role that the white blood cells circulating in your body do all the time. These are a little different. This is a lining cell that is ciliated, and it depends on where it is, whether or not it's flat, squamous, or it's more elongated, columnar. I know you remember those terms. Squamous, cuboidal, columnar. My personal favorite, pseudostratified ciliated columnar, because I love to say it. Okay, and what the cilia do, just like they move mucus around in your respiratory system, they enhance circulation. What they're circulating is cerebrospinal fluid. So you did the sheep brain dissection. If you looked inside the ventricles, you found like reddish brownish stuff that was in there. Did you notice any of that when you're doing the sheep brain dissection? Little reddish brownish debris. You open up the ventricles, the lateral ventricle, the third ventricle. Why not? WTF not? Okay, WTH not. Why the heck not? I don't want to offend anybody. In there, those are ventricles, right? They contain what? Cerebrospinal fluid. These cells play a role in cerebrospinal fluid circulation and, a little extent, in formation. You're going to see down the road that those ventricles have tiny capillary-like extensions. Particularly, we see them in the third, fourth ventricle, and the large ventricles. And so what they are called, they're called choroid plexes, Choroid, plexus, singular, plexes, plural, and they're covered in ependymal cells. And what they do is they really finalize what we call cerebrospinal fluid. Cerebrospinal fluid is somewhat of a filtrate from plasma, but it's not identical. It's not that we just filtered the plasma and this is it. It's got a lot of different levels of the components of plasma, which we don't have to learn here. But the short course is it has to be finalized. Comes out of the plasma, which is the liquid component of your bloodstream. It's finalized and then circulated. And we make about a pint every day, and we get rid of a pint every day. And we'll even look at the siphon-like arrangements where you're going to see in those same really in the meningeal areas when we start to look at the brain itself. So I'm just trying to give you the kind of what's going on with regard to it. So they line those cavities, the ventricles, as well as in the spinal column, and it's a permeable, which means stuff can move through it, barrier. Yeah. And that's the beauty of this barrier. The fluid can come out of the bloodstream at those capillaries and then effectively be this really extraordinarily significant fluid. I was asking the class before you, and because this is part of the discussion about, apparently you didn't really look in depth in spinal cord anatomy and things like that, and why you can do a lumbar puncture and that type of stuff. Okay. We're going there. We were going to go there anyway, but I'm having fun. We're going there when we get that's the next chapter, chapter 12. It's all part of the surface. You're all looking at me like I never want to see you again. And yet some of you have registered for micro. See, I've tried that with the registrar. Here's a list of the people I don't want to have, but I can't do that. I am not allowed to reject. I am joking. Oh my God. Oligodendrocytes. These are really important. The key issue, okay, is all this white matter. White matter is made of this unique substance. It's really a plasma membrane called myelin. It's a unique plasma membrane. What's plasma membrane? Proteins, embedded proteins, and fats. That's what myelin is. And it insulates and wraps and protects all the long nerve endings that are transmitting and receiving signals that we call white matter. Not every nerve has it, but this is what it is. And the oligodendrocytes are very, very unique in the way that they do that. And you're going to see that from the illustration. Okay, here's the cell. Here's the nucleus of the cell. It has multiple projections, sometimes as many as 60. So it can wrap part of the way around up to 60 individual axons or nerve endings, if you want to think of them that way, transmitting portions of the nerve. You don't have a lot of room up here for these billions of nerves that are up there. So they have, or billions of axons would be a better way to express it. These tiny microscopic hair-like projections that are there. So they have to be closely packed and held. That's the unique part. When you see the difference, the Schwann cell, here you've got a limited amount of space. When you look at the Schwann cells, they're in the peripheral nervous system. So they wrap around nerves differently Okay, because here you have space and room. Your sciatic nerve, your femoral nerve, your obturator nerve, your radial nerve, your ulnar nerve, your funny bone. Okay, all of those, they can move pretty freely. There's space, there's fatty tissue, there's loose connective, there's all sorts of stuff that are there. Okay, not so in the brain. So the oligodendrocytes are a close packing mechanism that also provides this insulatory layer we call white matter. These are called sheath gaps now. Don't know why. One of those things I have no control over. They changed the name forever. And the reason I tell you this is because wherever you're going to work, if you're in a clinical setting, and so maybe with an instructor, maybe one of the nursing instructors or health science instructors will say, oh, the signal in the nerve, and we're going to learn it this way, jumps not from sheath gap to sheath gap, but these little blank spaces. It jumps. In the old days, what most of us learned, they were called nodes of Ranvier. I teach it because I love to say it. I always think French is very romantic. Ranvier, not Ranvier. Love that. Let me have my small little pleasures, please. So and you're going to hear the term. They're nodes of Ranvier. I mean, hey, I told the other group, my middle son, who now lives in Weirton, used to live in North Versailles, except he used to say Versailles. It spelled the same way. So the satellite cells, they play a role, and you're going to see, we use the term cell body, okay, because we don't use the term nucleus. You learned about that. Nucleus in the nervous system implies clusters of cell bodies. Another term you're going to see when you look at nerve cells is soma or perikaryon. They are the nucleus and that nucleus area in an individual nerve cells. So satellite cells are there and they're similar. And that when it says similar, that's code for whenever you see permissive words in a textbook, maybe, likely, have been associated with blah, 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 blah. That's not definitive. That's short for we don't know. You use simple declarative statements. That is a sensory nerve. It conducts sensory impulses. You don't conjecture. And then so you have to understand that. Believe me, if you're working with people asking you and you're in a clinical field, there's nothing wrong with saying you don't know. I'm not shy about saying I don't know. I'd be a lot more worried if I forgot. Okay, so the Schwann cell, and again, just like a sarcolemma is the membrane, a neurolemma is a membrane of this particular cell. That's where it gets its fancy name, neurolemmacytes. But the Schwann cells, and you're going to see they surround the nerves differently because they're not constricted for space. Yet their membranes and associated proteins and fat, create this insulatory layer. And this is similar to the oligodendrocytes, not identical. And they play a pivotal role in regeneration. We will not talk about that here. In AP2, when you do peripheral nerve physiology, they may or may not, whoever is doing the lecture, talk about this. It's the reason when somebody has a tragic accident and an industrial accident where they've sharply cut off, transected is the appropriate term, part of a limb, they can reimplant an arm or a leg if they get to it, if it's handled properly and they get to it properly. There's nothing new about that. That and the fact the nerves will knit together. Even in a surgical sense, I had patients I operated on, the operation is great, but I lost sensation. And I had told them going in that you might lose sensation. And they come back a year later, just for a follow-up visit or with another problem. They go, "That's unbelievable. You're great. I got my nerves back." It's nothing I did. Nerves secrete a chemical that you don't have to know about called nerve growth factor. If the damage to the nerve is in these long transmitting ends called axons, the nerve growth factor, which comes from this lining, will help it regenerate. And that's the reason we can reimplant things if we get to them sooner. Very, very interesting. We didn't know about any of that stuff. Those were terms I never heard of 50 years ago. And about 1990 or so, I was at a surgical seminar in Hershey here, outside of Harrisville at the medical school, and one of their professors got up and says, "I've got some really exciting information." He studied nerve physiology, and we're all sitting there, mouths open. That's what it looks like. This is a sensory nerve. It's got a fancy name that you're going to learn about. It's called unipolar. Okay, and there it is, the cell body. It's offset. The liner here ostensibly is the satellite cells. If you put all these cell bodies together, it forms something called a ganglia. Clusters of cell bodies in the brain are called nuclei. Basal nuclei, you learned about the red nucleus, substantia nigra. That's a black nucleus or black substance. Remember those terms? Okay, that's where we come from. This is called a ganglia. And that's another term that we use differently. And I remove ganglia in joints. This is a very famous ganglia for those of you who are going on to micro. Okay, clusters of these sensory nerves, and these are called dorsal root ganglia. You'll see that when we look a little bit at the spinal cord here. That's where herpes viruses go latent, where they hang out. Because once you get a herpes virus, it is yours forever. Whether it shows up again is another question, but that's where they become latent. And you'll become acquainted with what's described as latency. Most of us have been exposed to herpes type 1 at this time. That is different than herpes type 2 or genital herpes. But that's a micro lecture when we start talking about viruses, kind of the middle of the term. These are the Schwann cells. They're different. You see, they go around one axon, one hair-like process of a nerve, and they do have the sheath gaps, except their nodes are around the end. So the nerves themselves are the structure unit. Very specialized. You only get one set, make the most of it. When a nerve dies, if the damage is here, if the damage, like I said, if the damage is here, they can be repaired. Not all the time, depending on the extent, obviously, but even with a traumatic event, even with an operation, a lot of times you'll get the function or the sensation back, as opposed to if it's damaged here in the nucleus area or the cell body area, it's going to deteriorate. That's what, and we're going to do a unit on stroke. It always gets me. People say, well, my grandma had a stroke, but the doctor said there was no damage. A lot of times, doctors and nurses and people in health, they talk to people and they use the wrong terminology, which you should not do. When somebody has what they call a mini stroke, it's really what's called a TIA, transient ischemic attack. So there's a fleeting lack of blood flow, and the person might black out, might see double, something bad might happen, lose their balance, potentially injure themselves. It doesn't mean a stroke, by definition, means brain cells have died because of a lack of oxygen, period. It's a heart attack. Same thing. Heart cells have died from a lack of oxygen. The question is whether they cause permanent impairment, or even if somebody noticed them, it's totally different. There's plenty of people have silent heart attacks, don't know until a finding later from another physical exam. Some people will just, oh man, I got a terrible headache. I just feel dizzy. They might have actually had a stroke, but whether or not it impairs them is a totally different matter. That's why I hate it when they're very dismissive. Oh, she's fine. She had one of those mini strokes. That's misinformation. I object to misinformation. It is important. You don't have to alarm people. There's a way of speaking to them, but you need to, if they're not going to understand what you're saying, they're not going to understand what you're saying. But you should at least try to inform them, give them some context, understand whatever you talk to them. So I do that little rant anyway because I think it's important. You can't make more. They're amitotic. You must have oxygen. You must have glucose. One of the things that you will learn, particularly when you do endocrine and you start talking, and you should, extensively about the most consistent clinical disease that you will see if you are in healthcare in a typical population: diabetes. specifically diabetes mellitus or sugar diabetes. You cannot know enough about it. Most people will tell you, well, when you have high blood sugar for a long period of time, it can kill you. Absolutely true. Very slowly. The diabetics have an other end risk. The thing that can kill them fast is low blood sugar, particularly insulin dependent diabetics who are, relatively speaking, brittle, hard to control. Classic example, it happened with my patients, arguably my favorite patient. Unfortunately, he's no longer with us. That's a whole other aside story. He was getting insulin every morning. He's running late to work. Took his insulin. I'll grab something as soon as I get to work. What happened? And he's fortunate. This is how it happened because he lost consciousness. He always said, "I remember when I parked in the car and was starting to get out of it. And the next thing I knew, I woke up in the hospital." And just like in the movies, they gave him a shot of sugar, and where am I? Perfectly fine. That's critically low blood sugar. That is something that can kill you right now because your brain stops working. While he was lucky, he was in the car and he didn't happen to lose it when he was driving the car and go into a tree or, heaven forbid, hit somebody else, which can happen all the time. That's the problem with sugar. And that's really in diabetics, and it happens so often. How many times have you been running late for class? I'll throw something on. I know I should grab something to eat. I'm hungry, but I'll get it later. It's worse if you're a diabetic. And the other is oxygen, and that's pretty self-explanatory. Your brain only runs on one sugar, glucose, period. Nothing else will do. That's why when you get to diabetes, why it's so vital, and education is so terribly important, because it's irregularities in sugar metabolism. It's not always high. Pre-diabetics go up and down like a bad day in the stock market. So I don't have to. My wife's into investing, so I hear about it. And so the cell body, other names, perikaryotersoma. I typically use cell body. Okay, it does everything. It's the nucleus, it has a nucleolus. It makes the membranes, it makes the chemicals, it makes these passageways. You're going to hear all about those at length. They're super important. A lot of times there's pigment. Chromatophilic typically means it likes color or loves color. Hence, we see them when they stain as pigmented. Red nucleus, substantia nigra. We identify them because they're the basal nuclei, because they have pigment. They stand out that are there. And typically the plasma membrane is part where it's receptive. And typically, you're going to see when we get to the terminology, it's called the dendrite, is the receiving end, and the axon is the transmitting end. That's it. For general nerves that we're going to study, that's a good construct. That's what we're going to get to next time. Again, when we get clusters of cell bodies in the CNS, they're nuclei. When they're in PNS, they're called ganglia, not identified. This is where we stop, and we'll start talking about dendrites and axons. Look at this construct, look at the impulse. We'll talk about all the different stuff that goes on with them next time, because I don't want to start a new unit. This is where I end up with the last group anyway. So we get done a little early. We'll resume in earnest on Friday. Whoever Ernest is.